Hello and welcome to another episode of the Melbourne Athletic Development Podcast. This episode of Lateral Think is brought to you by the support of Melbourne Athletic Development. We do this podcast because we like having interesting conversations with interesting people. We want to get better because we want to get better outcomes with our clients. If you have questions or need help with your performance or injuries, contact the team at Melbourne Athletic Development. Jack.
How are you, John?
Very good, mate. It's very good to have you back. For those who don't know, Jack actually spent some of the early January period over in Italy.
Indeed.
What were you doing, mate?
Well, I have signed up to do a 3-year training program in the fascial manipulation method.
Seems like you struggle with commitment, mate.
3
years.
3 years. And, well, you know, at the same time, too, that's one of the things that appealed to me because they're actually...
Depth, yeah.
Oh, totally. We've talked a little bit about fascial manipulation before. Just to give people some context, it's the fascial manipulation method by the Stecco family. So this is a method that originally was put forward by Luigi Stecco, who's this physiotherapist in Italy who clearly is a genius, was very curious and interested about understanding different methods and that a lot of these real old school therapists use, that are very much like an art form, and thinking, why do they do what they do and what's the rationale for it? Right. And we'll go on.
Let's back up. What is fascia?
It's interesting, actually. So,
and what even is connective tissue?
Yeah. Well, look, I look at the idea of connective tissue and fascia as interchangeable, okay? And
well, fascia is a broader term for parts of connective tissue, but it doesn't necessarily make up all of connective tissue because there are other types of connective tissue as well.
Correct. Look, the person to look at in terms of their research and actually talking about defining fascia is Carla Stecco, who she was one of the presenters in this program I'm doing. So she is a professor of anatomy at Padova University, which is actually where anatomy started. What's that Dutch anatomist, Vesalius or whatever his name was? No, not Versailles.
Vesalius.
Is it Vesalius? Yeah, I'm pretty sure.
Yeah.
He
was based there.
He was based in the University of Padova. So she's got a very prestigious position.
There's a very long history of...
Correct. She's done a lot of great work in expanding our understanding of the histological and anatomical understanding of fascia. But one of the big issues at the moment that's happening is people can't agree on what fascia is, because if you look at, say, the Gray's Anatomy definition versus, say, the Fascia Research Congress definition, there's variability. I tend to use the more broad definition of fascia of encompassing the whole connective tissue network when you think about things like ligaments, tendons, joint capsules, aponeuroses. I think it's easier just to classify them all within that fascial term.
And if we broadly define connective tissue,
yeah,
what function does connective tissue play? Because I think that'll allow us to expand into a lot of the ideas about even what you can do to intervene when it comes to connective tissue.
Well, this is where we actually need to start probably sub-classifying a bit, because I think the two clear different types of connective tissue or fascia we can think about is the superficial fascia, so that is the fascia underneath the skin, and the deep fascia, so that is the fascia of the muscle, so the endo, peri, and epimysium, but also the aponeurotic fascia, which I think is worth just briefly describing because people probably haven't really heard of the concept.
Again, go back.
Okay.
Connective tissue, what is it? What does it do?
Okay.
Right, because then I think we can talk about the subcategory of fascia and then the different types and then, as you said, the functions of those ones.
Yeah. Well, you can think of connective tissue as simply the network that connects everything. There's more to it than that because it's definitely biologically active. It's not just some inert structure that's just simply transmitting force from the muscle
or even just connecting things. Like I think that's probably it's a really key feature of what connective tissue is the fact that it does transfer particularly force across, or even tension across different planes, across different segments of the body and throughout chains.
Correct. And when you think about, from a musculoskeletal perspective, the role of fascia, because it does have roles in other systems too, but let's focus on what we do a lot of, is when you think about force production, we think about the muscle. Even when you think about the architecture of a muscle, think about the origin and insertion, a lot of people, I think, forget about the idea that muscles have a pennation. So it's not that simply a muscle has an origin of here to insertion there, and the force just transmits longitudinally to the tendon and then to the crossing the joint that the tendon is connected to. When it's pinnated, it makes you realise, well, hang on a second, if the muscle's pinnated, all the fibres can't be originating from the origin because some of those pennation is going to be away from the origin. And the reason for that is because when you think about a muscle, it's within a compartment, i.e. the epimysium, and that compartment forms the borders for which the muscles actually originate from. And then if you even think about it going to a more micro level, at a sarcomere level, sarcomeres don't go from the beginning of the epimysium to, say, the central aponeurosis, if there is one, if we're thinking about a pinnated muscle. They often fall short because they're not that long. But the way that they actually continue to transmit force is via the endomysium, which creates continuity within the sarcomeres, and then at a more macro level to the perimysium when you think about the bundle of fascicles.
Yeah, why is any of this relevant?
Because it helps you to understand more effectively how force production and transmission works, but also understanding the fascia's involvement in pathology.
Okay.
And
if we go back and take a step further back again, and I know I'm labouring on this point because I think it's one of the key central things to understand before we get into the details, is connective tissue exists for lots of different reasons. And I think one of the things that's highly been underestimated, particularly even in anatomical research, is the importance of it. Because to me, it actually is the central structure that allows for movement to occur.
Yes.
Right? And that's based on an understanding that uses a model, which I think we've discussed briefly, but it's a biotensegrity model.
Yes.
Right?
Yep.
Do you want to describe how these parts fit together so that we can then zoom back into what's happening at a more local level?
Sure. And I think a good way to help understand its importance is to look in contrast to how we learn and visualize anatomy. One of the big issues we have, and one of the reasons why fascia has been disregarded for a long time...
Yeah, it seems like it's been ignored almost.
Absolutely.
And there's even... For all those people listening who, I'm sure many of you have done anatomy classes before. And one of the things that I always found super interesting when you first go and actually work in a cadaveric, with a cadaveric subject, is it's all pristine. It's beautiful. You can see everything perfectly, and there's,
all the muscles look independent of each other. There's that clear origin and insertion. And again, very appealing because I think particularly for humans, we like order, we like structure. And so you go, oh yeah, quadriceps, we've got the rectus femoris, here's the origin and insertion. We've got the other quadriceps musculature. Everything is separate.
But it's not that simple, is it?
It's an illusion. And a term or a saying I've heard is anatomy is dependent on the anatomist because it depends on how they dissect the body. Because if you remove the superficial layers, so the skin, the retinaculum cutis, the superficial fascia in the leg, the next thing you see is not a muscle. The next thing that you see is what's called your aponeurotic fascia, or in the thigh, your fascia lata. So think about tensor fascia lata, the muscle. The reason why it's called that is because it's simply a muscle embedded within the fascia lata, that is this stocking that surrounds the leg, and that continues down into the lower leg to become the crural fascia. Underneath the aponeurotic fascia is then the epimysium of the underlying muscle, and then the muscle itself.
And are all these layers connected?
Yes. So
for the people who haven't seen this stuff before, haven't got a good understanding, how much of this is connected throughout the chain?
It varies depending on the muscle and what part of the muscle. So there is connection because between these very well organised layers of fascia, you have loose connective tissue. The physiological role of loose connective tissue is to allow a certain amount of independent gliding. And anyone that's looked at an ultrasound image before, when you get to see a muscle contract, you can see the muscle, you can see the more organised fascia, whether it be, say, the aponeurotic fascia in this example, which is white, and when you contract, you can see that sliding occurring.
And then between segments, say from upper body to lower body, how connected is that?
In the arms and legs, well, through the whole body, but in the arms, legs in particular, very connected. So to give you an example, and just thinking about, again, that aponeurotic fascia, the underlying epimysium, the loose connective tissue, there are points where there are myofascial expansions from the aponeurotic fascia into the muscle. So a good example is there's actually quite a well-defined one within the vastus medialis distally, and also I think in the vastus lateralis, for instance. So when you're contracting your quadriceps, you're getting contraction of all the sarcomeres, or whichever motor units are being recruited. That contraction then causes transmission of forces from the sarcomere to the endo-peri-epimysium. The epimysium is continuous with the tendon, for example, the quadriceps tendon, transmits forces distally to the patellar tendon, to the tibial tuberosity. But usually it's around 30% of that force will also be transmitted laterally, and in this example through some of those myofascial expansions, to the aponeurotic fascia, to the fascia lata, that then creates tension and actually can transmit forces distally beyond the knee. And that can be up to about 30% of forces.
So how does this information change the way that you think about, say, functional anatomy?
It makes you realise that we have to move beyond the idea of linearity within how force is produced and distributed. It makes a lot of sense too when you think about it from an evolutionary perspective, because back when we were in the water, before we even developed skeletons, we had just muscle and fascia. And a good visualization, I think a good representation of human movement and function is I think really about the musculoskeletal system being this fascial network that creates pockets where you have muscles within the pockets that can tension the fascial network to create lines of tensions to be able to either create forces and distribute and transfer those forces over longitudinal planes, but also to be able to distribute forces over a larger area. And this is something that I think is really valuable when we've talked before about things like ground reaction forces during high force, high velocity contractions like sprinting, is how do we actually manage to be able to tolerate
4 to 5 times body weight.
Magnitudes of forces much larger than our body, because if we use the simple model that unfortunately gets still taught a lot of, like
basic mechanics,
actin myosin, overlap, create force, transmit it to the
tendon. You would not be able to tolerate such forces. You would have failure of multiple tissues.
And you see some of the limitations of that in some of the models we have for, say, stabilization of the lumbar spine too. There's some very interesting research by Gastovesky, I think is how you pronounce his surname, of showing that some of these simplistic models we have of just thinking of the skeletal system, the musculature of, say, the abdominals, which interestingly have continuity into the thoracolumbar fascia. If you rely purely on muscle contraction to stabilize, say, the abdominal cavity, the forces required would literally cause an explosion of the cavity itself.
Okay.
And it seems a bit absurd, but it's like, well, what's the limitation of these models? The limitation is they don't take into consideration
the transference of
and the fascial's involvement.
I'm saying the transference across that network of
completely.
Fascia. Okay.
Now, I think the reason why we don't like to think about fascia is because it starts to add in this concept we always talk about of complexity.
Yeah,
and
it's not simple, as you said. It's not linear lines. It's not basic even to visualize these connections.
And just to give you an idea, like there's a study I think of. I can't think of the author's name off the top of my head, but they stretched. This is in humans looking at in vivo force creation when you stretch the gastrocnemius. And you kind of think of like, surely as you stretch the gastrocnemius, you get this nice linear increase in tension through the whole muscle tendon complex. That's not what happens at all. You get some areas where it goes up, you get some areas where it goes down in tension. So straight away you have to think, what the hell is going on there? Like, aren't we stretching the two ends and it's becoming...
And it's obviously not happening in one plane, is it?
Absolutely not. So straight away it's like, well, why is that? And it's like, it's because of the complexity and dispersion of the fascial network, that for an individual you'll have some areas where there is more tension because there's more fascial laydown because of their movement patterns, their training history, but there'll be some areas where that won't be as prevalent, and that's just a reflection of the adaptability of the fascial system.
You just made me think of a number of like sporting examples where you see people moving particularly in different planes to maybe the direction that they're traveling or the force that they're trying to create, and it's always, the commentary is always, if they didn't do this movement, they would be even better again.
Well, I think of the example we've talked about before of someone like Christian Coleman, which you can obviously...
Or even, I think the other one that came to mind as well is that you look at some of the Chinese weightlifters.
Sure, yeah.
And then when they squat down, their knees go in and everyone goes, oh, well, they're obviously, not strong in their, glute med or something like that.
No, clearly, yeah. They must be really struggling with that, lifting, 200 kilos when they weigh 70 kilos themselves.
And it's an interesting idea because they are clearly using the movement and, as I said, the tensioning, detensioning, and changes in position in order to create force and tension in the areas that is going to maximise your capability of lifting that weight.
Well, and again, if we just think about it from a simple anatomical perspective, this makes a lot of sense when you think about the anatomy of, say, the glute max, which is obviously a key prime mover for something like extension.
Squat,
So again, where does glute max originate from? You've got a lot of it from the thoracolumbar fascia and from what do you call it? The part of the innominate posteriorly, the glute max, I can't think of the name right now, fossa. But then it comes down, and the biggest insertion it has is into the lateral intermuscular septum and the iliotibial band. In fact, 80% of its fibers go into that. Yeah. So think about if you're creating a certain amount of dynamic valgus in the knee, you're creating tension through that lateral band that helps to then make sure it's stiff enough for force transmission, not to mention potentially increasing the length-tension relationship of the glute max to maximise its force production. Now, again, we can start to think about, is that useful for running and change of direction? That's another discussion. But for a weightlifter, there's a reason why they do that. And again, thinking about the iliotibial band itself, it's also reflective of a very unique evolution in humans, because if you look at, say, the iliotibial band in, say, apes, it's actually not that well formed or developed because we went from four-legged to bipedal. Yeah. And when you think about running on one leg, we need to have a lot of lateral stabilization.
Well, I remember seeing even in one of the anatomy books that I had, and I don't remember the statistics, but essentially if we didn't have an iliotibial band, we would fracture the neck of our femur consistently.
Yeah, sure. Well, I think of that again too, of like even say with development of stress fractures in your foot, particularly with sprinters or jumpers. I mean, obviously they do get stress fractures, don't get me wrong, but part of the ability to mitigate the accumulation or concentration of forces within the bone is the ability to disperse that through your soft tissue network. And, part of that is also based on how you move and how effectively you move to create tension outside of the skeletal system.
In terms of, because I think it's important that we tie these things together.
Yep.
In terms of the development of pathology when it comes in relation to connective tissue, because obviously we're going to have a lot of people listening to this from two ends, one being performance, one being, healthcare. In terms of the performance, I think it's pretty clear that if you understand that transference of force, you get an idea that maybe the picture is not what you think, and that if you can learn to create, as we just said with the squatting example, the ability to create tension, as you said with something like dynamic knee valgus, you may actually open up capabilities that were not previously obvious to you.
Yeah.
In terms of the development of pathology, what are the things that you tend to see in terms of fascial or connective tissue pathology that leads to, or actually one, what does it lead to? What are the presentations that we see? Because we'll obviously get onto what you can do about it.
Yep. Well, let's start with the more, I think quite well accepted classifications of, say, like muscle injuries. Because if you look at, say, British athletics classification, the Munich classification consensus, the Barcelona Football Club classification, they're starting to create...
People like creating their own classifications.
Oh, they do, don't they? Yeah,
it's a bit of a wank, isn't it?
Yeah, and like it's particularly
so similar.
Totally. Some of the terminology is a little bit different, but they kind of all mean the same thing. But one of the things that's becoming clear is this, very simplistic idea of you've got a grade 1, 2 or 3 hamstring strain is just so limiting in our understanding of prognosis, particularly, where I think like the British athletics classification system's really good. There are some limitations with it because it doesn't take into consideration like contact injuries, because it's really related to sprinters. But you think about what tissue is involved is the big one. So is there tendon involvement? Is there muscular involvement? And if it is muscular involvement, what part? Is it just purely within the muscle fibers? Is it more of a fascial-related injury within the epimysium? Is there also a tendon involvement as well? And then if so, how much? And this helps to explain a lot of the things that we see clinically, because there are times when people have a hamstring strain, and interestingly, sometimes they might present quite badly initially, but then within 10 days they're better. And the classic one is, particularly if there's, say, a bit of epimysial involvement, but no tendon involvement, if you disrupt the epimysium, the bleeding in the muscle is going to go out of the actual compartment. They're going to have a lot of bleeding that you'll see visibly. I think also too, psychologically, that has a big impact on you. There might be a significant amount of deficits, but then they actually recover really quickly, as opposed to, the other end of the example of there's complete central tendon involvement and there's separation, which clearly reduces their function, but more importantly too, as they start to maybe get some improvements in, say, force output, when you start to do high velocity contractions, you realise, they just can't do it still. So there's a clear acceptance and realisation that when we think about muscle classification, and particularly when you look at MRI, you need to think about what connective tissue is involved.
Yep.
And again, we can think of tendon as connective tissue. I just look at tendon as being much well organised, and that the collagen fibres are aligned in one particular plane and much more dense, as opposed to, say, a poneurotic. Well, a poneurotic fascia is probably a little bit further down the spectrum, where there's not as organised, and then you can think of, say, joint capsules, which is much less organised. So it's really helping to understand of this idea of it's a grade 2 strain is actually not useful clinically or even radiologically to help understand the potential prognosis. Now, again, just looking at the MRI is not going to be the best prognostic indicator by itself. There are some exceptions, like if there's clear tendon involvement and separation, there might be indications for you need surgical management. But most of the time, it's kind of this grey area of it's more significant, it's less significant, but let's consider other factors associated with complex adaptive system, i.e. the human. Where it starts to get a bit trickier is thinking about non-specific pain and presentation.
And I think that's a big differentiation, isn't it? We often talk about that, of the difference between an acute injury and a non-acute injury.
Correct.
An acute injury being, it's a known incident, you're walking, you trip over, you roll your ankle.
Yep.
You're running, you feel something pop.
Yes.
You have contact, and you develop a fracture or a corky or something like that. It's a well-defined point in time in which that injury it was initiated.
Now, and before we go to the next part, we even, I think sometimes too, when we think about, say, fascial involvement of, let's say, where there's non-contact injury, i.e. someone strains their hamstring sprinting, is there dysfunction of the myofascial network elsewhere within that kinetic chain that causes a concentration of forces in the hamstring? But
we'll talk about that
that's
later,
another
maybe.
thing, I think, too.
Then there's the non-acute side, where it's this insidious development. Typically it's of pain, but it can be of other sensory information that people receive, but they'll typically report, okay, I'm getting discomfort in this particular area. Can you describe what the presentation is likely to be in someone who's presenting with connective tissue, say, symptoms?
Yeah. Well, again, some of these are pretty well understood and classified. If we think of, say, a distance runner developing medial tibial stress syndrome, that's non-bony related, but a lot of the pain comes from irritation of the fascial insertion into the periosteum of, say, the tibia. Or, we can even potentially think of, say, tendinopathy as well being on that spectrum too, where it's you've got an overload of the connective tissue component that's particularly involved in the stretch shortening cycle. But then when we start to think about these people who come in with non-specific back pain, so that is, clearly from their presentation, subjectively and objectively, there's no articular involvement, or non-specific neck pain. Or the other ones that get tricky too, of the runner who comes in, it's my hamstring's just been really tight. Was there an incident? No. Can you still actually produce a lot of force and velocity? Yes, for the moment. Of course, so it could be that niggle could also be indicative of potential damage later on. But you need to think of, what's actually going on there? And as we start to improve our understanding of the fascial system's involvement, the physiological role of fascia and the potential pathological role, we can start to appreciate where a lot of this non-specific pain is originated from. Because you can do, like, this is very prevalent in the general population, most people have non-specific low back pain when they present with back pain. If you do an MRI and you look, where's the tissue involvement, it's either inconclusive, or the other issue we have too is there's a lot of false positives, as we know.
Degenerative changes within, say, disc structures or...
And the issue we have in that is when we think about the fascial tissue, it may not actually be disrupted in the sense that you look at an MRI, it's like, well, the thoracolumbar fascia in the back seems to be okay. The issue that we have, and this is a problem that is being solved by Antonio Stecco and his group, is, well, are there some subtle changes, well, maybe not subtle, but changes within the extracellular matrix of the fascial system that change the biomechanics of how the different layers of the fascial system move that can generate pain? And this is, in fact, exactly what goes on. When going back to thinking about the anatomy of the human as being multi-layered, and that we require gliding between different layers to occur for normal sensory motor function, for normal transmission of forces, that actually can change. And that can change when we start to see changes within the loose connective tissue. So I'm not talking about the well-organised layer, I'm talking about the loose connective tissue that in normal physiological circumstances essentially acts like a lubricant. It allows the gliding to occur. But there can be changes that occur in the extracellular matrix. So specifically in the involvement of what's called myofascial pain, which describes these kind of non-specific presentations, what you see within the loose connective tissue, which has the same elements as, say, deep or dense connective tissue, are the cells, the fibroblasts and fasciocytes. There's collagen fibers, and then in the extracellular matrix, you've got the glycosaminoglycans and proteoglycans that bind with water to create this lubricant. We see changes where a particular glycosaminoglycan called hyaluronan, which typically binds to water and typically creates that lubricant, it stops binding to water and it starts binding to itself. And when it binds to itself, it changes the thixotropic properties of the tissue, i.e. the viscoelasticity. It becomes more viscous, it becomes more glue-like, and it reduces the gliding. And this is something that we see in a lot of people with chronic low back pain. There's some really...
with the studies that Antonio is doing, is he finding... What associations are they finding between those gliding properties and presentation of pain? Now they're able to quantify that, or are they not at that point yet?
No, so this is where it gets really interesting. So some of this work originally is from Alan Langevin, who's a researcher in the States, of looking at, just via ultrasound, of looking at the different layers of the thoracolumbar fascia, because there's some very well-organised layers of the thoracolumbar fascia. Look at Frank Villard's work. Where when you do, so like an anterior pelvic tilt or posterior pelvic tilt, you see this gliding occur. And in people with long-term low back pain, it's just stuck, doesn't move. And that's important because there's the other thing that people neglected for a long time is the fascial system innervated, highly innervated. And within the poneurotic fascia, like the thoracolumbar fascia, there's a lot of free nerve endings that can produce nociception. And so the current hypothesis is that as you create this increase in tension because of the lack of gliding, those free nerve endings, which are mechanoreceptors, become much more nociceptive in nature, start sending signals that there's pain, there's something wrong here. Antonio's work is trying to help quantify what that change is. And so he's using a novel method of using MRI and using a particular MRI called T1-Rho. I don't know enough about the technology behind it. Read some of his stuff or talk to him. But what you can use with T1-Rho is you can see that in these types of non-specific presentations, I think for his it was actually like lateral epicondylalgia in non-athletic populations, where you can see that you can quantify the amount of unbound water. Because again, normal circumstances, when the different layers are gliding, it means that at the loose connective tissue layer, the hyaluronan is bound to water and it's creating an effective lubricant to allow gliding. In a more pathological state, where you get the hyaluronan binding to each other, you're going to have all this unbound water. And that's exactly what you're seeing. You're seeing that when you look at symptomatic versus asymptomatic people, you can see that differences, and there's a lot more unbound water within that area of the body. And this is where, I mean, we'll talk a little bit more about, well, the changes you can potentially see with certain interventions. But this is where, and I've spoken to Antonio about this, of like, what do we need to do next? And he goes, we need to be able to quantify non-specific pain or myofascial pain, because it's all well and good to go clinically. You don't fit into any particular classification. You've got non-specific back pain.
Yeah.
But if you want to get some actual acceptance of that from the scientific community, you need to be able to quantify it. And rightly so, I totally agree. So we're starting to move towards this ability to be able to create essentially another subclassification, which I think is actually really important, because at the moment,
I feel like there's a gap, particularly in the non-specific low back pain, where it's like people get pushed into the too hard basket. They don't fit mechanical pain. They don't seem to have even degenerative changes, or if they are, they're not seemingly clinically significant.
Absolutely.
And so they go, oh, well, we don't know why you've got pain. And then they tend to go, well, potentially there's, sensitization and centralization, but it's not helping these people.
No, and look, I mean, this is not to criticise all the people in the neuroscience field who have shown the central changes associated with long-term pain. I mean, for anyone that's had a significant injury where, you've got pain for 3, 6, 12 months, it's pretty natural to develop some level of sensitization, because no one likes being in pain or discomfort. And I'm not saying that there isn't a role for, say, psychological input to address those factors, but
are we missing something?
Well, and as you and I have experienced clinically, as I'm sure a lot of clinicians have, and in fact there is some research highlighting this too, I think one of the issues is that people have misdiagnosed someone, and sometimes that's a more clear misdiagnosis of like, actually you've got a stress fracture, that's why you've got pain. But I think the issue is, well, you've got non-specific. What we do for that is general exercise, general education, and the thing ergonomics, which are all relevant things.
Well, generally, we'll talk about it in a moment, but those things will actually have some effect
Absolutely.
on those, as you said, thixotropic properties of the tissue, but maybe not enough for it to be clinically and long-term beneficial for that individual to be at a point of like very little or no pain.
Correct, yeah. And look, I think this is where some of Paul Hodges' work is really valuable, because he's showing... It's very interesting to see where Paul Hodges is heading with his research of thinking, well, how does fascia involved in back pain? For him, that's what his area of interest is. And how do pathological changes within the connective tissue system change over time, and the interaction of that system with the immune system? Because this is where the value of something like physical activity occurs, is from physical activity you're creating changes within your immunological response and the inflammatory status, which provides the chemical signals of where the connective tissue becomes, i.e. more fibrotic, which is kind of like the end of the spectrum of pathological changes to the connective tissue versus staying in a normal state. What I'm describing here with non-specific pain is basically fits in between, because think about what fibrosis is. It's the lay down of collagen in a really disorganized fashion, which is what occurs when you don't apply appropriate forces through that area of the body, and or inappropriate chemical signals or hormonal signals causing an inappropriate laydown or excessive laydown of collagen. In this myofascial pain, where you're getting changes within the loose connective tissue in the extracellular matrix, that's somewhere in between, because what essentially is happening from normal to pathological is you start to get initial changes in the distribution of water and hyaluronan, which changes the tension. And when you think about it, if you've got this increase in tension over time, the way that the body will respond was going, I'll lay down more collagen, because you're actually creating more tension and more forces. So it's like,
trying to almost like reinforce
absolutely
the need to stabilize that position.
Correct. It's just in this situation a maladaptive response.
For people listening, even as a therapist, like what will that feel like? What will you actually feel or see or experience when you're maybe potentially palpating that tissue?
Yeah, and this is where some of the fascial manipulation method and looking at the application of all the research from the STECO and other groups into clinical practices becomes really valuable. And it's interesting, I've thought a lot about this, of like, because you go over to Italy and you can see like these guys have really refined their method, and it's actually very big. It's very big in Italy, it's very big in a lot of European countries.
Are you allowed to talk about this, or are you going to get shot?
Well, I'll ask them before we publish it, hey? But these are just my observations anyway. This is not theirs. It's actually really big in the States. It's not very big in Australia. That's why I'm going to Italy to learn about it. But is the value of palpation to feel the quality of the tissue. And when you think about some of the biomechanics of the fascial system I've talked about, is how well or effectively the different layers glide on each other. And again, they've done some research to look at, is this actually reliable in terms of our ability to feel this, which they've shown that it is. And what that actually feels like over time. Because I think we're confident with maybe two ends of the spectrum, or maybe what feels normal and what feels fibrotic. So like the classic example would say, particularly say post-surgery, if someone's had a surgical incision, you can feel that scar tissue, but what it feels like in that in between.
Question I have for you is, because it's a commonly question you even get from patients, is where does something like people describing, I feel like a knot in a muscle tissue, where does that fit into this equation? Is that a presentation of connective tissue dysfunction?
Yeah. So
where would that sit on that spectrum?
So interestingly, when you look at the idea of a knot or like a trigger point, what is that? It's a black spot, and the black spot is representative of the fact that you've got this accumulation of hyaluronan and no water bound to it. So
this is exactly what you're describing. You're getting these accumulations of area where the tissue becomes more dense, it's not sliding.
Correct.
And it starts to, even under your palpation, you can feel an area where that tissue feels more fibrotic in nature.
Well, it may not be fibrotic because depending on how long it's been there for, fibrosis doesn't usually occur.
I'm saying it feels more like that rather than necessarily being fibrotic.
Correct. And you use a word there, dense, and this is a term that that the Stecco group uses, and they talk a lot about this in their research of densification. And that describes changes within the extracellular matrix I described before.
So you would describe something like a trigger point or a knot as a densification in this terminology?
Yes, yeah, and it explains what a trigger point is. Yeah. It also helps explain this idea of myofascial referral pain. So I'm talking somatic referral or like non-radicular referral. So I'm not talking about nerve root compression causing radicular pain. I'm talking about that much more achy pain that can actually be quite broad in how it presents. It helps to explain it because if you look at the Travell and Simons definition of referral pain, somatic referral pain, they think it's much more neurological. So you get this afferent signal back to the spinal cord, and then due to the interneurons at different levels, it may produce pain elsewhere. The issue with that is the response of where you experience pain varies so much from person to person. And part of that has got to do with the laydown of their fascial network based on their genetics and past training history and physical activity. Because as you find with myofascial pain, you feel a trigger point or a densification in the glute, and it can refer all the way down to the ankle, or it might wrap around and you might feel it in the inside of the knee. Or the other really interesting one I always find is you're palpating lower down the leg and it starts referring up. Because I always think most people think of referral pain as going proximal to distal. That's definitely not
always
the
case. Yeah.
No. So one of the potential tools you can use for changing the constituents of the extracellular matrix is using friction specifically. And again, this is something that they've shown to create changes within the fascial mechanics, where as you apply concentrated friction, it starts to heat up the area, which we know, at least in the short term, will cause a dispersion of hyaluronan, but it will come back together. That's why when you warm up from training or you go in the sauna, you feel really flexible because it reduces the viscosity of the loose connective tissue, and not to mention it also changes the chemical properties within the muscle and deep connective tissue. But you feel really flexible, but it will come back. But the application of that friction, that shear force, will cause the hyaluronan to break down into fragments, which over time will wash out. So you won't get an accumulation of too much hyaluronan. And then you get the secretion of new hyaluronan from fasciocytes, which is a unique cell within the fascial network that will create enough hyaluronan appropriate for that area of the body to then make sure that it connects to water, not itself, to restore normal fascial mechanics.
We'll get on to other things that might affect this, but specifically on things like frictions, what kind of utilization of frictions are you talking about? How long are you doing it for? Are you concentrating it on that area of densification? And what effect are you trying to elicit?
Yeah, look, this is where you start to get to a layer of complexity, and something it's difficult to talk about too much now, but I use a particular method for assessing to try and identify what are the potential planes involved with someone's presentation of pain and what areas of the body are involved. Because one of the things that's done very well with the fascial manipulation method is understanding not just how to treat potentially the symptomatic area, but how their past medical history and prior injuries may be contributing to alterations in the fascial mechanics and compensation of that elsewhere in the body that's led to the development of pain in their back, thigh, wherever it may be.
But at a basic level, say someone presents, you've assessed those things, there doesn't seem to be anything other than, say, low back pain, and you feel like there's some densifications around that thoracolumbar region.
Yeah.
What are you doing in terms of applying some sort of friction, manual therapy?
Yeah, so there's particular points that you learn about within this particular method, and once you identify what you're going to treat...
Actually, can I ask, you say that, what are these points, and do they relate to things like, these areas of densification? Are they common, or are they different from person to person?
No, they're quite specific about where these points are. And again, the fascial manipulation method uses this concept of what's called centers of coordination, which relates to based on the biomechanical model of looking at what are the muscles associated with that movement in that region, and what are the accumulation of the force vectors where they may...
So they tend to accumulate in one spot. And does that mean that you tend to get, say, densifications in those spots? Is that what you're suggesting?
Yeah, I mean, technically you can get a densification anywhere. And this is where it gets much more into the clinical experience, that these ones are the ones that create the biggest changes in the sensory motor and biomechanical behaviour of that region within that plane. Just
so I can clarify, so you're saying that's sort of where the tension that's created from the tissues in that area tend to kind of almost amalgamate to a central spot?
Yes.
Not that that's the only place they can be, but
absolutely,
that's kind of the philosophy that they've built from the research that they've done.
Correct. And they've got different points based on the different planes. So sagittal plane for flexion extension, frontal plane, horizontal plane. There are some other points, but let's not make it too confusing for now. So with regards to your question too of how long does it take to feel these changes, it does depend on the person's presentation for how long they've had it. So like if someone's got, it's certainly much more recent in terms of the development of their pain, they've got no prior trauma, this suggests that there might be some maladaptive changes over a long period of time. It can change pretty quickly, like 30 to 60 seconds. Again, the Stecco group have done a study to look at how long the changes on average. I think it was like 3 minutes and 20 seconds. I'd say typically it doesn't even take that long. But again, there are some times where it's like they had an injury 20 years ago and they've been dealing with this problem for a long time, and it may take longer than that. But the changes certainly can occur within a reasonable time when working with someone clinically.
And in terms of, you mentioned applying that, so that's clearly a method that you're using relatively often.
Yep.
Are there other interventions that you are looking to affect these connective tissue networks that aren't necessarily manual therapy as well?
Oh, yeah. I mean, look, again, anytime you create tension...
No, but what I mean is...
in terms of like outside of exercise or...
No, I'm saying like what... And for instance, for some people this is going to be new, this idea of like tissue gliding and looking at higher... What are the other kind of areas? Like obviously you've already mentioned you can actually mechanically agitate that tissue, and that in itself will start to create the response that you want.
Sure.
What other things can you do? You obviously mentioned temperature, something that may have an effect. Are there other modalities, interventions, exercise therapies that you could use to actually start making changes in that for the patient as well?
Sure, yeah. I think in terms of mitigating, the most useful one I've found is stretching. Again, there's some interesting research looking at Helen Langevin's lab of stretching. This is in animal models where prolonged active stretching, and active is an important component.
Where you're actually contracting at the same time.
Correct, which actually makes sense when you think about it, because it's contraction of the muscle...
It's asking the layers to actually sort of
glide. And also too, as you contract the muscle, you're creating more tension within the fascial network because of those myofascial expansions, where stretching for a prolonged period of time can secrete essentially anti-inflammatory compounds, which can help to maintain balance within that inflammatory milieu that drive some of the pathological changes within the connective tissue system. So I think stretching on a regular basis is very useful for mitigating. Interesting to say though too, you often see a lot of people with non-specific back pain or non-specific pain or indications of densifications building up, where stretching can be actually problematic.
Why is that?
Well, because if you think about, say, doing something as simple as a forward bend stretching, which most people think of stretching as the hamstrings, which absolutely does, but if you're doing it effectively, if you're doing it actively, it's stretching that whole posterior chain from the plantar fascia in the feet all the way up to the glia capitis in the head. And imagine, and again, think about this sliding component. If one point is stuck, or potentially multiple points, as you stretch it, instead of getting an even distribution throughout that whole network and the different layers, there's one point that's stuck. So it's going to cause too much stretching above or too much stretching below. And again, just where the densification is doesn't always mean where the pain is too. You've got to remember that. So that's something that I've certainly observed clinically, where with non-specific pain, getting them to do lots of stretching can actually cause more symptom production. I also find it quite a useful outcome measure and actually diagnostic indicator as well in those situations.
So seeing where they feel the stretch, or actually seeing where movement doesn't occur? What are you observing there?
I think potentially like as an indication of someone presents with a condition that's non-specific in nature, it clearly doesn't fit into a classification of articular involvement or neurological involvement, that, okay, this is probably much more something related to the fascial system. But also too of like, okay, well, there is their pain. I think the thing that's useful here, and this is where, you really open yourself up for criticism, but this is where I also find it fascinating of like, do I need to treat that area? And, this is where you start to really appreciate and actually use a method of like, can I be methodical about how I assess someone and determine whether their pain is maybe in their back, but maybe I need to actually treat away from that area. Like, a basic example may be I've seen a few people like this of they had an ankle sprain 6 months ago and they're presenting with back pain, and you think, is there a connection between these 2 points? And you find that there are feelings of densification within that, around the calf, for instance. And when you treat that, you see changes in their symptoms, you see changes in the mechanics of their movement in their lower back region.
Explain that, because if you say that to someone, they're going to think you're crazy. Explain why changing, and I know that you can deduce this from what we already said, but like put it in layman's terms, why would treating, say, densification through the calf or ankle complex affect the movement in the lower back?
Yeah, so again, this is something that's been really well established when you look at the mechanics at a tissue level of, think about when you do something like an anterior pelvic tilt. And again, you think, okay, what are you changing or tensioning there? The obvious one is the hamstrings, for instance, because you're taking the origin and insertion of the hamstrings away from each other. Absolutely true. If you look at, say, more distally, we see that when you think about the deep fascia, so again, at the calf, when you think about the crural fascia and then the underlying calf, you see that there's sliding occurring between those different layers. And again, this is reflective of the fact that the fascial system creates continuity and force transmission across areas of the body where there may not actually be movement at a macro level occurring. Because when you think of an anterior pelvic tilt, you think of just the hip. The knee isn't moving, the ankle isn't moving, but at a tissue level you see movement of the fascial system relative to the underlying fascial layer. So when you think about what's going on there, if you get a densification where you lose that gliding, that's going to create changes within the biomechanics within that fascial layer further up. And what can happen over time is if you're creating, say, excessive tension in that particular plane in the hamstrings or the glutes or the back, that can then start to create pathological changes also again within the loose connective tissue that formulates a densification, which then helps to or contributes to the generation of pain in that area. So, again, if someone, using that very basic example, if someone presents with back pain and you're thinking, why does someone present with that back pain? Again, I don't want to oversimplify it, it's probably multifactorial.
Yeah, I think the key message is obviously you're going to this when you feel like there are not factors that are more local that would explain it with, it's like Occam's razor, essentially. You're not jumping straight to, the ankle did it. It's when you're ruling out a number of these other signs. And it's not that it doesn't contribute as well, but you're assessing everything. You're not just going, no, I'm going to disregard the fact that it seems like there's potentially, degenerative disc disease because it's definitely the ankle.
And look, we talked about this earlier and you asked that question, which is a good question. Is like, as I learn more about this, how do you stop yourself from becoming biased? Because,
if you find a method works and you want to use it all the time.
And look, the reality is we see that within our own profession, there are different trends and some people get exposed to a particular method and all they do. Yeah, totally. And I think this is where it's useful for us. We create a framework as we learn more knowledge of like, what do we see as prime modulators for musculoskeletal problems? And we've talked about tissue capacity, we've talked about biomechanics, we've talked about hormetic profile. I see this as just another component. I see it as another component that we need to be considerate and cognizant of, but at the same time too, we don't want to just assume that, everything's complex and it's all about the fascial system and we need to treat always away from the area of the body.
I think we spoke about this during the week, and I think one of the definitions we probably need to change is not necessarily just calling it capacity, but calling it, like tissue qualities.
Absolutely.
And that fits into both its ability to create things like tension, but also, as you said, its ability to move and, what the actual properties of that actual tissue are.
Yeah, and look, I think about this too when we think about concepts such as motor control. Well, I think one of the issues we currently face is even using the concept of motor control assumes that's always as output.
Yeah.
And I think something that we do really effectively in sports medicine, high performance, is think about how can we improve output, i.e. exercise modalities, changing mechanics and so on. But it's not motor control, it's sensory motor control. One of the things, and one of the large things that influences the behaviour and the ability to recruit motor units and contract muscle
is input.
Is input. And like we know this from a simple standpoint of like, how do you feel performing when you've really sleep deprived? Absolutely shit, because your higher cortical function is compromised. And it's same peripherally too. If someone strains a muscle or sprains a ligament, why do we see changes in their output? Because of peripheral sensitization, because of afferent signals saying, I'm not letting you recruit this muscle right now, or at least that portion of the muscle, because we can't put too much tension in there, you're going to screw us over. And again, thinking about more of these non-specific problems, we can start to then appreciate when looking at the growing body of literature that one of the afferent inputs that can affect our output is the biomechanical behaviour at that more tissue level. So, again, it's always one of those things. I think a lot of people love to like put you in a box of like, Jack just does this fascial manipulation stuff and it's a little bit out there, which, I'll accept to an extent. But no, at the same time too, I don't think that we should be thinking that this is the solution to all answers, this is the solution to all answers. No, but
as you said, it's an evolving part of understanding features that often we put in the too hard basket. I think that's one of the things that's starting to elucidate is like people with, particularly, I think the big area, as you mentioned, both what Antonio's looking at, people like Paul Hodges, is, this non-specific back pain. That's, in my mind, and I think you would probably say the same thing, that's not a good enough answer.
Yeah, I agree. The language actually isn't appropriate at all. And look, I look at it as simple as something like, if someone presents with a hamstring strain, we always use that framework of what's the problem? Hamstring strain should be pretty easy to determine. But then you want to think of, why is that a problem? And again, this is where we start to get into that complex nature and multifactorial nature. And that could be something as simple as, all right, this person actually rolled their ankle 6 weeks ago. What's their capacity like at their ankle? You look at things like range of movement, you look at things like strength, you look at things like their power elastic function. Because we may start to get changes in the myofascial system based on that biotensegrity model of how we maintain appropriate tension and stabilization, and how we actually create compensatory patterns when we develop deficiencies in a particular area of the body. And all this we're talking about with regards to fascial mechanics and its pathophysiological changes we see, I see as just another component to that.
Yeah. All right. Is there anything else that you wanted to explore with this that you think might be useful for listeners?
Well, look, I think the biggest thing is these are concepts and constructs that probably may be quite new to a lot of our listeners. What I really recommend is go and look at some of Carla Stecco, Antonio Stecco's research in particular. They've done a lot of publications in the area and they continue to do it. It's one of the things I think that's really drawn me to their work is they have a particular method they apply clinically, but they're trying to do the research too to help validate what they're doing.
And obviously the other one, I think, as you've mentioned, he's obviously doing some work with the Steccos is Paul Hodges. I think some of his research is really interesting, as you mentioned, like the direction it's starting to go.
Absolutely.
For our Australian listeners, they probably have a little bit more awareness of who Paul Hodges is.
Yeah, and look, that's something I'm actually interested to continue to follow because, like anything, we go through different pendulum swings with what we do. I think at the moment in physiotherapy, we've gone very much from being very manual therapy dominant to going very exercise dominant. And I think that's been to our benefit in many ways and understanding the value and importance of exercise to injury management and rehabilitation and mitigation. But I think we've moved a fair bit away from considering how manual therapy is being involved. There is some justification for that when you think about the paucity of literature related to manual therapy, even though we actually understand a lot of the mechanisms behind it. I think what we need to do is get better understanding the benefit or the cellular response of different types of manual therapy and the model that we use for thinking of how we need to think of not just the musculoskeletal system but the myofascial system being interconnected. That adds a layer of complexity which does really challenge how we think and view anatomy and human body and movement. But at the same time too, with that comes opportunities to understand how we can improve outcomes by being better understanding complexity and how we actually provide or construct assessments and interventions to address that.
Alrighty, I think we'll obviously probably hit on this at another point as well, because I think there's many layers to this. But Jack, thank you very much for sharing some of your information that you've been accumulating over the last few years.
Happy to help, John.